Hello, I'm Faith Rogers, host of today's program, COVID-19, Keeping Up with the Moving Target. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC, AAPA, and AMA-PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the Claim Credit button on the webinar console. Otherwise, please go to covid19.dkbmed.com, navigate to our multi-specialty episodes, and select the webinar to claim credit. Today's learning objective is to discuss new FDA authorization for second booster doses. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, as well as in-kind support from DKB Med. With us today, we have Dr. Paul Auwaerter, the Clinical Director of the Division of Infectious Diseases at Johns Hopkins University School of Medicine. Dr. Auwaerter, thank you so much for your time today.
Yeah, thank you so much, Faith. And I think for many of us, as spring comes across many parts of the country, we have found the rates of COVID lower, hospitalizations and unfortunate deaths much lower. All good news, and many states have shed their mask mandates. But in recent week or two, there's been an uptick again, often in schools, universities, where there have been increased number of cases that seem to be due to the BA.2 lineage subvariant of Omicron, which is even more infectious than the earlier, more widely circulating Omicron variant. And this seems to be the trajectory of this virus, that it is enhancing its transmission, in part because there's more pressure. People have gotten the infection or vaccines, and this particular virus does seem milder, which is indeed good news, but especially for the unvaccinated or people with significant health problems can still pose grave illness. And indeed, it's no surprise that the Omicron variant is now worldwide, just about in every place that's been looked for. And again, I think this just speaks to its extraordinarily fast pace since first identification in November that is now present worldwide. And indeed, it's really the predominant isolate found when sequencing is performed in many countries of the world. And here, as you can see in the CDC genomic surveillance data, it is maybe 85 to 88%, which is, again, a very rapid rise, very similar to how Omicron replaced the Delta variant. And we're just seeing this almost on 2 to 3 month intervals of these new variants that emerge and quickly establish themselves and become the predominant virus. So after that decline that I spoke of, and I think there is certainly a sigh of relief, not only in the medical profession, but by public health officials and elsewhere, there is a slight rise if you look at the tail end of the top graph, where it had been flat, and there's a subtle uptick in the past week or so, although the number of people hospitalized or dying, of course, continues its decline because that is a lagging indicator. But you can look to the left of tests and see that those have not continued its decline, which, even though there's home testing now, does state that there's still continued interest, perhaps not as strong as in January, of continuing to check oneself for some sort of viral type illness. One of the more frequent questions I got asked by colleagues, also patients, are about boosters. As many of you are aware, in late March, the FDA approved booster number 2, and this is for anyone over the age of 50, or if you're immune compromised, you can now get a 4th dose of vaccine. And the rationale the FDA, I think, based this on was data from the United Kingdom and Israel that showed that people that in the summer of 2021 got the first booster had waning immunity and therefore were more susceptible to Omicron infection. And this was blunted by the second booster. And so interestingly, some of the early data, again from Israel, suggests, though, that this protection against any SARS-CoV-2 infection starts to wane by week 4. And this is even faster than the amount of, or the timing of the waning, I should say, from the first booster. So it looks like each additional dose gives you a boost, but it doesn't last as long. But importantly, it does seem that people remain protected from severe disease, which again, I think starting with the Delta variant last summer was really the message we were trying to convey to patients. And of course, the BA.2 variant is one that I think the FDA is trying to stay a step ahead. And of course, other countries have taken the same path, including Israel and the United Kingdom. Now, do boosters work? And I showed you a little bit about the fourth dose. We have somewhat more robust data about a third booster, of which only a minority of people in the United States have received. And this is some data assembled by the Centers for Disease Control that was presented to the Vaccine and Related Biologics Advisory Council, to the CDC, FDA. And this compared the effectiveness of the vaccine, both those who only got 2 doses and those that got 3. And although a somewhat busy slide, I draw your attention to the bottom row, where you can see that 3 doses clearly shifts to the right. The effectiveness against preventing critical illness and death. And that also includes in all categories examined, including hospitalization, emergency room visits, and also infection. So this is just from the third dose, and probably the message I would say is if your patients have not gotten the first booster, that would be a priority at this stage. And the fourth booster may help a bit, but there is some sense of diminishing returns. So this advisory committee struggled with issues which I think, looking ahead, do pose challenges and remain without clarity. And that is, well, given the boosters, what's our frequency of these? Will they be directed to only some, such as people over 50? And why 50 was chosen is unclear. In Israel, it was people in their 60s. Does everyone get one? Some experts argue that none are needed, because we're really saying that the first booster protects very well against serious illness. Of course, exploring whether the composition of the vaccine should be changed from its original Wuhan strain to the so-called ancestral strain to something that's currently circulating like Omicron. When do we pull the trigger and say it's not working? At what level of reduced either vaccine efficacy or reduced ability to keep people out of the hospital? Interestingly, Peter Marks at the FDA said that if there's a vaccine change, it would be wholesale. It would have to be every vaccine available would have to change, and otherwise it would be too confusing. And also, I think any major change sounds as if they would demand some clinical trial evidence, and you couldn't just substitute, which is really what happens currently with influenza immunizations. But of course, that is much better in the sense of our understanding. Lastly, there are still remaining questions about immunity. Although there have been some human challenge studies for which we're beginning to understand the correlates of immunity, there's been great focus on the neutralizing antibodies, but others have argued for a long while that T-cell responses are actually a better way of anticipating what's necessary to prevent from severe infection and death. And I think there'll be some additional looks at patient populations at vaccine or even natural immunity T cell responses to better understand if this is better to keep a better correlate for severe illness protection or death compared to neutralizing antibodies, which probably are the best for just preventing any infection in that case. I did want to just spend one quick moment on an update from some data which the CDC assembled about cardiac involvement from the vaccine. And there were concerns about this raised early on with a change also in the EUA and also advice that perhaps vaccines could be spaced out further in the groups that seem to especially suffer rare complications of immunization, such as myocarditis, such that instead of getting vaccines at 3 to 4 week intervals, it might be stretched out to 8 weeks in these risk groups. But I think the important consideration, and the top of the CDC slide is cut off here, but basically the young men and boys both have a higher risk of cardiac involvement with COVID disease than they do with the vaccine. That's both teens and also men under 30. So I think the message here is that these groups still benefit from immunization there. And of course, we're still waiting for the under 5 group to have their additional studies looked at and whether that group can be immunized as well. But generally, the sense is immunization. Certainly, children don't get as severe illness, but there is still benefit from immunizing this group. Well, the pandemic has produced a number of unfortunate health consequences and deaths. However, it's really some of the additional factors that we, in at least healthcare, think less about that is as important, I think, for anyone in healthcare to think about, but also for public health authorities and importantly for those that control the purse strings. And so what I'd like to do is just briefly go over an important concept called excess deaths. Now, standard and official death counts have recorded somewhere between 6 and 7 million deaths due to COVID worldwide. This could have been far higher if there weren't the mitigation strategies in that first 9-10 months of the pandemic in 2020. And then, of course, there was as much of a shift to immunization efforts through the 2021 year with rollouts. But it does appear that if you look at countries' official death statistics, there appears to be excess mortality far above anticipated baselines compared to pre-pandemic, such that many have come around to think that the number of deaths actually is far higher. So you can see here perhaps threefold higher, more than 20 million deaths. And this picture gives you a bit of a map, at least for data that's publicly available, to get a sense for the countries so much affected, such as Peru, South Africa, and Russia. Those that were certainly affected, including Brazil, United States, Spain, and so on. And then those that were less so in the lighter yellow. And these collateral effects include a number of things of which I'm sure you're all aware of: supply chain issues that are affecting us to this day in many areas, cars, fuel, shipping, and so on. Costs, which of course are not just pandemic related, but certainly that is a big component, has fueled many countries in terms of debt rise. And the International Monetary Fund has judged that the total cost of the pandemic, and this is just at something from 2022, was judged at over $12.5 trillion. We see newspaper articles, which again, I'm not sure it's the pandemic's the only cause, but certainly the correlation appears strong. For example, road rage, gunfire deaths, murder, for example, violent crime, all rising during this time frame. Pedestrian accidents, which are thought to be more distracted drivers, higher anxiety levels, and that has continued through 2022. I think you've seen in a number of countries relative unrest, general unhappiness, often with rules being imposed, for example, restrictions of freedoms and these sorts of things. And the thought is that moving ahead, this kind of turbulence and some of the real stressors and inequalities will continue to fuel unrest. And so the IMF, again, for what it's worth, and is just a group that has interest in this, looks at pandemics. And here we are in year 2 or 3, but their sense is you can easily look 5 years hence and see that the social unrest tends to continue to rise for a period of time, and that the social unrest factors even add to the economic damages and stressors that are beyond the pandemic. So this was all a bit of a argument to say that this is not the time to let up on pandemic preparedness. I know after wars, there's always a military buildup beforehand, and then it's decreased. But we never really started at a super strong point, because if you look at the image on the left, has the United States at one of the highest scores on index security. And this was in March of 2020, just before the pandemic. But yet, I think we can all say that certainly we could have done a better job, had a better unified public health structure, responses, communication. And so I think there's work to do. And there's, of course, a lot of potential aspects at really preparing a response so that we can anticipate what are often viruses, and therefore stay at least closer to intervening in a rapid way than we have in the past. So, Faith, just some food for thought, and I'd urge people to write their Congress people and just say that very appreciative of the congressional monies that have gone into handling the pandemic, but this isn't the time to pull that away at this point in time, especially since I think the upcoming year still remains to be seen what will happen. And although there are encouraging signs, there's still, unfortunately, surprises that this virus has continued to offer us.
Thank you so much. The first question here is, what is the status of other COVID-19 vaccines that were in development? So Novavax, for example.
Well, Faith, a good question. Certainly the mRNA vaccines have been the leader, I think, compared to other strategies, including adenovirus-based, also inactivated vaccines. So I think many of those, while there continues to be effort at developing other vaccines, they were first out of the box, as it were, and I think their impact makes it hard to knock them off. However, people do have side effects. I think it's always good to have alternatives. And the Novavax vaccine is a different kind of vaccine, one that has a approach which it uses protein subunits, and of course people might be able to manage taking that vaccine if they cannot get one of the mRNA vaccines. This vaccine was presented in application. The company did for an EUA to the FDA at the end of January of this year. Its status is still pending. However, some companies have gone ahead and distributed it, so it is in use, for example, in Australia. So I think the data is encouraging enough that we'll probably see the FDA take action, but I also think there's a hesitancy not to try to complicate pictures, because if you're trying to keep abreast of all the vaccine changes, it is a challenge to know how certain groups, boosters, some of the booster recommendations have been changing and so on. So I think there may be some effort to give people a time to get used to the current recommendations before introducing an additional vaccine. But that's just a guess on my part.
Dr. Auwaerter, thank you so much for those updates. If you're tuning into our webcast, please click the Claim Credit button in the webinar console to attest for credit. Otherwise, please visit us at covid19.dkbmed.com. Again, thank you for joining us, and thank you for your dedication to your patients with COVID-19.